how has your target market and channels to sell into that market evolved?
Great question. I think this go-to-market strategy is probably the hardest thing, and maybe any startup, but definitely in healthcare, definitely in social impact. Our initial hypothesis when we were back in the day tinkering around with pitch competitions and venture competitions and things was, oh yeah, self-insured employers, they will want to pay for solutions that make their workforce healthier, and that should be a good enough place to start. And it is on the surface, but then you learn about the nuance of these employers. They're getting tons of people knocking at their door, trying to sell them stuff. They don't really want point solutions unless there's something very compelling about what you're doing. And if you're like a brand new startup with nothing but a slide deck, it's very unlikely that you're going to get very far unless you're doing a lot of legwork and finding those super users, early adopters. We weren't sure if we had the time or the runway to figure that out. So we knew that there was still a huge opportunity in the self-insured employer space, and particularly if we targeted specific groups like trade unions at the time was high on our radar. But since then, we've also evolved our kind of strategy on the employer side. But in order to get to a point where we can pilot, get the validation, build the product, we wanted to try and follow the breadcrumbs to where the most acute version of the problem and patient group was at. And again, it was like, it's not employees that are going to their employer looking for help for their addictions. You know, there's like some friction there. It's people at medical center who have like significant social needs and other chronic comorbidities, also heavy smokers, and the medical center clinical network is the preeminent sort of safety net hospital in the Northeast, and they see a lot of this kind of need. So we through a lot of cold calling and stuff, we managed to get into the respiratory team. They have like a weekly meeting where they really care about trying to help the smokers, even though they don't have much budget or money to pay for stuff. At least we knew that there was like a credible group of people who actually cared about solving this problem, and there was a critical mass of people who need them solved for. And we spent a lot of time shadowing those clinicians and building trust and getting that clinical, expertise and their insights infused into the product. And we saw that, okay, having that clinician in the loop was super important. We could theoretically pitch action as a way of them increasing their throughput and making more money or generating more kind of patient engagement and doing more work, more things for those patients. But even that proved to be challenging at first, like getting clinicians to change the way they did things and adding yet another tool into their toolkit was tough when they're really time poor. So we made the decision to say, well, if they don't have time to use our tools, what if we did what they were doing? We hired the clinicians to do that work and build the tools that our clinicians that we employed, so that we could learn by doing and develop the product in that way. So again, just following the breadcrumbs of just let's one problem at a time and then see where we go, and try and articulate a strategy around this, which would probably be like a 3, 4, 5 year horizon of executing certain things to get to a promised land of having that big contract come through, in order to like develop the product to a point where there was some really unique IP and some real problems that were solved for. Needed to kind of take on that burden of being the provider ourselves. And then we took the slightly, I guess, naive step of becoming a provider ourselves, getting an MPI number and saying, well, if medical center can bill for this work, like what does it take for us to be able to bill for it, so we don't have to like trouble them to do this work, you know? Can we do the billing and just keep all the margin and be completely vertically integrated? Which is what we did. Like we actually got an MPI number as an entity. We got a couple of physicians, and one in Michigan, one in Massachusetts. We entered into these fee-for-service contracts as an in-network provider from the bottom up, with plans in Michigan and Massachusetts, and just went to market directly, to collect the patients, find the patients ourselves, receive them, treat them, engage them, collect the data on them, build the product around them, refine the product so that we had some really kind of unique IP around, okay, like here's like a virtual first direct to consumer healthcare offering that's solving like a very specific problem for a very hard to reach, hard to engage population. If we can figure that piece out, even though the reimbursements are kind of shitty, like we're making a bet that by getting that IP, getting that insight, we can pique the interest of a larger payer, an MCO, an ACO that has like a large volume of this kind of population with other comorbidities. If we can prove that we can activate and engage them and generate patient outcomes with them, even with this narrow vertical, there's so much more value in being able to do that for the payers or risk-based providers that really struggle with this population.